Welcome to the Mayo Clinic Ophthalmology Podcast, brought to you by Mayo Clinic. I'm your co-host, Dr. Brittany Scruggs.
And I'm your co-host, Dr. Eric Bothan. We are here to bring you the latest and greatest in ophthalmology, medicine, and more.
Today, we're joined by Dr. Barbara Tylka, an optometrist at Mayo Clinic in Rochester and the founder of our multidisciplinary dry eye clinic. She specializes in advanced dry eye and ocular surface disease. Tune in to hear practical dry eye strategies to improve clinic efficiency and patient experience.
We're joined by Dr. Barbara Tylka, an optometrist here at the Mayo Clinic in Rochester, where she founded and directs our multidisciplinary dry eye clinic. Her practice focuses on advanced dry eye and ocular surface disease, particularly in patients with complex systemic conditions and those suffering from neuropathic ocular pain, and an area that is often misunderstood and under-recognized. She is a fellow of the American Academy of Optometry and lectures regionally and nationally on dry eye disease, ocular surface disorders, and practical real-world strategies to improve both clinic efficiency and patient experience. Dr. Tylka's work bridges science, systems-based care, and compassion, particularly for patients whose symptoms don't match their exam findings. Welcome, Dr. Tylka.
Thanks so much for having me. Looking forward to the conversation.
I will admit it's a treat to have you here. I personally say it's a treat to have you in clinic because we all have certain patients that we get nervous about if we're not doing enough for, if the current opportunities in care are not in our practice. And in the dry eye world, I see the dry eye patients, in particular people with monocular double vision, that get sent to me for binocular double vision. And I go, wait, you need to see Dr. Tylka. But no, it's wonderful to have you here.
No, thanks so much.
Yeah, I echo that. I mean, I can do a retinal detachment repair, or close the macular hole. If that surface is rough and dry, they're not getting the, all the benefits of my surgery. And I commonly cause dry eyes, right? Anytime we operate on the eye, we're putting the patients at risk of this. And so if we're not addressing it, then we're not, potentially doing the best care for that patient. So I love having you as a partner.
Thank you.
Because of you, I think I talk about dry eye more than I used to. I know that's true. So I appreciate this conversation, truly. Yeah.
Before we get into the details of dry eye, can you share with us your career path in terms of where you're training and how you got into dry eye being something of interest?
Absolutely. So I did my optometry school training in Chicago at the Illinois College of Optometry. And then I did a residency at a VA hospital in Fort Wayne, Indiana. And then afterwards, I went into private practice. First, I was at a referral center. So I always like to think of that referral center as almost like a fellowship for me because it was very heavy disease-based. So I learned a lot. And then life happened. We had a baby and we moved. And then I ended up at a very large optometry practice. And this was a practice with, I believe, 10 to 13 providers. And that is the practice where I was exposed to some of the dry eye technology. And then when it comes to clinic, and you've all kind of touched on this already, I saw the unmet need when it comes to these dry eye patients. And my thought process was, do I get frustrated every time a dry eye patient comes into my clinic, or do I embrace this disease and learn all that is out there? Because I suspect, just like both of you, most providers in eye care, there's probably not a day that goes by that somehow you're not touched by dry eye. From a surgeon standpoint, again, for great surgical outcomes or what happens after surgery, dry eye there. From maybe a non-surgeon standpoint, even vision, right? I always tell my patients, because sometimes they come in to see me and, for example, say, no one's been able to get me the pair of glasses where I can see. And I always like to say, you could spend $1 million on your glasses, but if the surface of your eye is dry, it's just not going to work. Same with contact lens dropout. So dry eye is very important, in my opinion, in the surgical and non-surgical areas of eye care.
So in the last, 5-10 years, the field has changed quite a bit, both technology, even like the definition and how we define dry eye. And how does that affect how you counsel patients? How do you talk about dry eye with patients? How do you even define it for them?
That's right. Yeah. So this is actually a really great place to start this conversation because the definition of dry eye has really changed. And the change in that definition impacts how we practice and what we do for our dry eye patients. So when it comes to the definition, usually most of us use the reference of the TFOS-DUS reports. Those are essentially reports. The first one was published in 2007, then we had one in 2017, and then the most recent one was actually just a few months ago. And TFOS stands for the Tear Film Ocular Surface Society, and DUS stands for Dry Eye Workshops. So this is where experts from all around the world come together, and they try to come up, and they have done this beautifully, with a global consensus on everything related to dry eye. Because I'm sure we can all imagine this. If we don't have a good definition, then we're all speaking a different language, right? And then the prevalence numbers are completely not making any sense because what I call dry eye may not be something that you call dry eye. So the newest definition from, again, just a few months ago that was published in the American Journal of Ophthalmology is that dry eye is a multifactorial symptomatic disease characterized by the loss of homeostasis of the tear film and or the ocular surface. And we think of four main or four core etiological drivers of dry eye. And those include tear film instability, a state of hyperosmolarity, ocular surface inflammation and or damage, and also neurosensory abnormalities. So a very loaded definition, a lot of buzzwords in that definition, but it's those buzzwords that drive our treatments, that drive our testing, and that drive future research. So again, because the definition, in my opinion, has gotten so much better, our stats on the prevalence of dry eye have already improved, and I suspect they will continue to improve.
It's phenomenal how much it's changed. When you think about it, it used to be just do a Schirmer's test and see how wet it is. Right. And now we realize the complexity of the lid architecture, the inflammation.
That's right.
It's just there's so many other components to having fertile soil for a healthy environment on the surface of your eye. So absolutely. How is it, as Brittany was suggesting, how has that changed your approach to a patient?
Yeah.
Like when you just thinking about, it used to be here, take artificial tears, but talk about what you have to do coming in a room to start to understand this complex multifactorial condition. What's your approach when you step in to see your first patient? What do you start looking for? What do you start asking about?
Yeah, so the best thing you can do is try to identify as many drivers as possible for why your patient is suffering. The newest definition of dry eye disease really focuses on drivers. So like you mentioned, Eric, it's not just tear quantity and quality. That is, I think about those and I look at those measurements, but that if all I did was that, I would really not be successful in managing or helping my patients feel better. But those drivers, in that definition, it was loss of homeostasis of, yes, the tear film. So we think about oil and water, but and or ocular surface. And you already alluded to this. Ocular surface can be the eyelids, the conjunctiva, the cornea. So when you enter a room, as a dry eye provider, you're not going directly to the slit lamp. You care about what's happening to your patient's face. Maybe they have some rosacea. You look at the eyelid anatomy. Maybe their eyelids are lax. Maybe they have redundant conjunctiva. Maybe they have lagophthalmos. So all of those things contribute. Their lifestyle matters. So that's why, in my opinion, you do need to spend some amount of time with these patients, especially initially, because really you want to get a good history and see what in their life, and then obviously your tests help you with this too, is contributing to the problem.
So let's talk about that. So obviously the exam's important. You just shared like the number one thing is look at this, but we want to figure out the right subtype or subtypes, right? So oftentimes it's multifactorial. So what tests are the most important, and how do you make sure you don't over-test? Walk us through what's available and what's really high yield for these clinics.
Absolutely. So I would break it up into what kind of clinic you're in. So if you're in a clinic where you see a high number of patients, so maybe if you see 30 to 40 patients, dry eye patients a day, that dry eye workup will look different than what my dry eye workup looks like at Mayo Clinic, because I see usually probably around, let's say, 15 patients a day on a dry eye day. So for the providers that see a large number of patients, I would use, it's as quick as 1 to 3. I would, number one, get the symptoms. So I would use the OSDI 6 questionnaire. So that's just 6 questions. It's easy, and it's something that would be done before, obviously, the patient enters the room. Number 2, I would do an objective test, if you can, that tells you that there's a loss of homeostasis. So that could be your osmolarity or your non-invasive tear breakup time. And number 3, I would also do staining. So corneal staining, conjunctival staining, lid staining. So ideally, I would do questionnaire, objective homeostasis test, and I wouldn't skip out on the stain. But if we strictly follow what the TFAS 2 diagnosis of dry eye is, all you need is symptoms and one sign. So you don't need to even do 3 things. You potentially could do 2. And then honestly, at that point, if you diagnose someone with dry eye disease, I would bring them back and spend a little more time identifying drivers, because that's the thing you would do next, is you have the testing that you did, you diagnose dry eye, and then the drivers that you can identify at that visit, you identify. But if they're there for a comprehensive eye exam and you're also talking to them about cataracts, about their macular degeneration, you're not going to have time, and you don't want to kind of, skip out on the good stuff. So you can introduce the fact that they have dry eye disease and say, okay, let's come back and just focus on that. Now at Mayo, we have a little more time with these patients, because usually by the time these patients get sent to me, they're probably at least like moderate to severe category of dry eye. And again, we have a little more time with them. So what we end up doing is we do the OSDI questionnaire as well, the one with 12 questions. We also have our own questionnaire that helps us identify historical treatments that may have worked or failed, contributing factors, lifestyle. So these questionnaires are done and given to my technicians, and then my technicians do all the testing for me, and that includes Inflamadry, which checks for the presence of MMP9s, the tear lab, which is the osmolarity testing, and then they do imaging on the Oculus 5M keratograph. That's what we own, and that is the meibography. We measure the tear meniscus. We look at the non-invasive tear breakup time, and then I've really started checking corneal sensation on all the patients as well. And that's when then the patient enters my room, and I am able to see what they've done, what has worked, what they have failed, and I don't repeat those tests every time I see the patient. After that, to me, what's most important is what my patients feel and their quality of life. Now, maybe if I, started some treatment where I really want to know numerically where they're at, I care about the numbers, but I mostly care about what my patient feels, and that's what I follow is again how they're doing.
Go ahead.
I have 2 questions.
There's so many questions.
My first one is for people that may not have access to expertise like yours. What are things that they're usually forgetting? And maybe one would be staining, but as you brought up, that's often not done. So what would be the low-hanging fruit to help them? And then secondarily, you threw an extra thing in there, which is corneal sensation. A lot of people do that differently, and I'd just like to know how you test for corneal sensation in your clinic. So first question would be, what do people, if they pick up a couple more skills, what would they be, or questions? And number 2, how do you test for corneal sensation? So
I would, staining, as you mentioned, Eric, very important. And it's interesting how easy it is to miss some of those findings unless you put the stain in. So do the stain. Do the sodium fluorescein, do the lissamine green stain. The easy thing that nowadays we have a really good treatment for and is really easy to see and to treat is Demodex blepharitis. So look at the lids. Have the patients look down for 1 second, and you can easily see the cylindrical dandruff at the base of the eyelashes. And lotilaner is a drop that that the patient uses twice a day for 6 weeks, and it works so well. And we have to remember that blepharitis, Demodex blepharitis, that contributes to our patients' feeling of itching, eyelid swelling, inflammation. They just don't feel well. And a simple little 6-week course, it's not chronic treatment. How beautiful is that? It's just a little course that can make them feel a lot better.
So if you see that on exam and they're having the symptoms of itching,
yes,
then you would start that.
I would start that, yeah.
Oh, okay.
Okay, you brought up Demodex. Can I just say, my understanding is 90% of us have Demodex
I have a hard time thinking about this.
living. I know. By the time you're like a senior citizen, the
Sure.
majority of us are home to these things.
Absolutely.
So my question is there any evidence that prophylactically treating all of us, when we're aware of that, because in youth it's very uncommon. Over
Sure.
our life, the Demodex population increases in prevalence. Is there any value in doing it intermittently for someone who has no symptoms, or as they age, or is it better to wait until you have blepharitis issues?
I would say symptoms. Because here's the thing: if you're not symptomatic and you have a little bit of blepharitis, then why even prescribe anything? At that point, recommend conservative therapy. Most of us, as we age, need some sort of an eyelid cleanser. So at that point, I would recommend eyelid wipes, hypochlorous acid, a spray. So I am all for lotilaner and treating it, but I believe that because then you treat the patient, and maybe there is some financial aspect to this as well. Maybe the copay is not zero, and you have them spend money on a treatment that doesn't change their life. Plus, and I don't think there's enough evidence to where long-term you are really harming them by not treating it. So that's why I think symptoms have to happen.
That makes sense.
And then corneal sensation testing, how would you do?
Yes. So we do the Cochet-Bonnet in clinic. So there are also tests out there to check corneal sensations that are automated. I believe one is called Brill. We use just a little filament, and the reason why I like it is because it gives me a number, right? So 6 centimeters is normal sensation, 5 centimeters is normal. When you get into the 2-3-0 category, we have patients with no corneal sensation, then you've got a neurotrophic issue. You can also use, I know clinicians can use cotton wisps, dental floss that's been unused, but Cochet-Bonnet it's not really expensive. It's a very simple concept. And again, I love the numbers associated with the measurement, because then once I treat someone, maybe with therapies that are regenerative, then I recheck the corneal sensation, and I like to see numerically that I've made a difference.
So we've talked about exam and testing and listening to the patient, but you brought up the surveys. So for the physician who maybe isn't expecting to talk about dry eye, right? They're there for something completely different, and then they look in and they're like, oh, I think this is dry eye. I need to talk about it. What are the must-have questions that just right off the bat, you can ask these questions, you can say, yep, we need to either have another referral, we need to get you into the dry eye clinic, or we need to have you come back?
Yeah, so the most important things that would drive probably a provider to act on dry eye or maybe refer a patient would be discomfort and vision issues, right? Because no one's going to tolerate feeling like there's something in the eye, burning, foreign body sensation, or we don't want to tolerate that, and we shouldn't. And also visually speaking, we don't want, post-cataract surgery patients being unhappy with their surgery, not because they didn't have the best cataract surgeon and implant, but because they're dry. So again, symptom, it's individualized therapy, and the patient kind of drives that. With the newest definitions of dry eye, we focus on individualized therapy. And again, in order for it to be dry eye disease, the patient has to be symptomatic. And most of those symptoms end up being discomfort and poor vision, fluctuating vision specifically.
I know you see patients, you're commenting on the complexity of many of your patients. My understanding your clinic is multidisciplinary, and what does that look like? How often do you engage other services, whether rheumatology or pain medicine, or talk about how that collaborative work happens as you're evaluating these patients here at Mayo?
Absolutely. So, that's why working at Mayo is a treat, because we have fairly easy access to those other providers, those other specialties. So we have a relationship with the rheumatology clinic where there are slots on my calendar where I see Sjogren's patients, and then I refer my patients if I suspect that my patients, for example, have Sjogren's or other autoimmune conditions. So, I want to make sure that they're treated systemically and that their body is doing well, and then I take care of the eyeball. We also have relationships with the pain rehab clinic because we probably see a higher percentage of neuropathic pain patients than other dry eye clinics, just because Mayo is usually seen as kind of like my last try before I've given up. And these are just severe eye pain patients where maybe they have some dry eye, or maybe they don't have dry eye at all, but they are in severe pain. And those relationships with neurology, where they can help them with their nerve pain or chronic pain, and pain rehab clinic that I got to visit maybe about 1 to 2 years ago now, really again approaches treatment for these patients not just on a medication. They don't just probably medications, my guess is the thing they worry about the least. They have therapy for these patients. They have physical therapy, so many different ways to go after pain. And I'm not a pain specialist, but there's a physical and an emotional aspect to pain, and those patients at the dry eye clinic honestly probably tend to be the toughest. But the best we can do as providers is really validate what they're feeling. It sounds kind of funny, but sometimes those patients are embarrassed telling you what they feel because they don't want to be labeled as crazy. Yesterday I had a patient that was explaining nerve pain to me. It sounded like she was getting, lightning jolts in her face. And when she was explaining it, she later told me that she didn't want to tell me about this because she ends up almost like moving her head to try to avoid these jolts of pain. Because, the body wants to do everything it can not to feel that terrible pain.
Yeah, I'm sure that's really frustrating for these patients. The symptoms and the signs don't match a lot of times. So they may be miserable, and then we look at it and we're like, well, it doesn't look that bad. And that's not necessarily what you want to say. Like, you want to help and give them hope. So what is the most common cause of neuropathic pain? And what are like the clinical signs where you're like, yeah, I think that's what we're dealing with here for this patient?
Yeah, so clinically, the beauty of the dry eye clinic is I can look at the objective dry eye testing that, again, maybe tells me they have mild dry eye or no dry eye at all. I've had patients where the objective testing looked perfect, but again, the pain was 10 out of 10. So rely on some dry eye objective testing just so you don't miss anything. You can do the Preparicane challenge, which is just putting a little bit of anesthetic in the eyes. And the pain in the neuropathic pain patients tends to be different than the nociceptive pain in pure dryness, right? So with the dry eye, we usually think about grittiness, burning, foreign body sensation. With the neuropathic pain, it's a lot more severe, maybe lightning, maybe needles, and they will rate the pain as 10 out of 10. And when you put some anesthetic in, there's no improvement how they feel, right? If the pain is nociceptive and it's related to the surface, to normal dry eye, we'll call it, then, I always giggle and say my patients should want to steal the bottle of Preparicane because that's what makes them feel like $1 million. The neuropathic pain patients maybe have mild improvement in symptoms. And if they have mild improvement of symptoms, I think of peripheral sensitization. So maybe there's still room for me in those treatment processes, because then I think about the corneal nerves and everything I can do for them to make the corneal nerves as happy as possible. And the way you make the corneal nerves happy is by addressing inflammation, maybe considering some treatments that are regenerative, educating the patient about what's going on. But once the pain has been centralized and once someone really is experiencing central sensitization, that's almost like a brain problem, right? And again, most of the time that I spent in that exam is validating what the patient's feeling and telling them that this is going to be quite a journey that they're going to be on. And yes, it's important to rule everything out and make sure you're not missing something. But if everything turns back to be fine on tests, that doesn't mean you don't have a problem. You just have a problem that we can't see. And again, that's where neurology and pain rehab is very helpful, because I won't prescribe those specific medications for the patients.
So just in terms of counseling those particular patients, I mean, in one sense, I feel like it's a similar coaching or hand-holding you do with normal dry eye patients, in addition, to the neuropathic pain, because you're managing something that's chronic, that may not go away, that you want to validate their symptoms, but also get them to buy into a treatment. When in the neuropathic pain group, when do you refer them? I mean, because there are patients that have pain that seems meaningful and the symptoms are mild. When do you make that trigger? What steps do you take before a referral would be given to a pain management clinic?
So if it's a new consult, and again, the testing looks normal, but my patient's in severe pain, I don't wait. I mean, those patients have already been suffering. If the nervous system is dysregulated to the point where there's central sensitization, that usually means that problem has been going on for a very long time. Again, if they have what I suspect to be peripheral sensitization, usually I will start my therapies. But I always like to say that, let's put these other orders in, because even if you have to wait a couple weeks or months to get in for these other visits, at least we have them pending. And I always say it's easier to cancel than to make these appointments sometimes. Again, I had the pleasure, and it was not so nice, to have some nerve pain in my mid to late 20s. And I sometimes feel like things happen in life to us for a reason. And I was diagnosed with trigeminal neuralgia, and it ended up being a tooth problem. But I had that nerve pain for 3 years before that was discovered. So, and I remember going to doctors and being like, I don't want to say anything because I don't want them to think that I'm high maintenance, that I'm making this up, because the pain was so severe. So the quality of life of these patients is, maybe they're so light sensitive to where they can't sit in the room with the lights on. So honestly, there's really no waiting. And I hope for all these patients, I mean, if they have a root cause, 100% absolutely, I want them to find it. So that's why I say, keep looking, because I don't share my story with everyone, but if you happen to have a cause, oh my gosh, miracle, right? One day you go from 10 out of 10 pain to then the other day nothing. I mean, that is life-changing. But unfortunately, that's not the case for most of these patients, and they end up having to learn to live with the pain and manage it.
Yeah. It sounds like you're an amazing optometrist, and we're really thankful that you're here. But to just hear these patients, not only to validate them, but to tell them that there are other people like you, and that there potentially could be a reason. Thank you for what you do. Let's pivot a little bit. I want to talk about mild dry eye. So you said a lot of the patients who are referred to you are in the moderate to severe category, which means a lot of the mild dry eye is being managed by everyone else, right? Potentially in even the retina clinic, which, that's all I can speak to, but I see it a lot. So could you help us, all of the rest of the world who are, listening to this, what's our 5-minute algorithm that we can say, warm compresses, which artificial tears, the eyelid scrubs, like what is the algorithm we can just give them and say, try this. If it doesn't work, then I can refer you. But, hand out a little spiel.
And that's what I would do. Yes. Yeah, that's exactly what I would do. Is I wouldn't spend the time typing all that. I would have a smart phrase. That's what we call them at Mayo Ready. And on there, I would, write very basic statements like dry eye is a chronic condition. It's multifactorial. Consider using, for the most part, I stick to brand name preservative-free drops as much as possible. Now, yes, if you use the drops less than 4 to 6 times a day, you could go to the bottles. But being a dry eye person, I just don't like preservatives, right? We've had, I always tell my patients I'm not opposed to generic products, but since I came to Mayo a little over 3 years ago, a couple years ago, we had some issues with some of those other brands. So I'm still not comfortable enough with the generic versions. And my guess is there's probably numerous ones out there that are fine. But because of the troubles we had, I say stick to brand names, preservative-free products.
How about the stuff that you can put in them, like the brand name Mega 3, or you add this or that?
Absolutely.
What do you recommend? In the fancy add-ons?
Right. So, first of all, there's no studies comparing, right, the different drops. And most dry eye is evaporative in nature. So most of the time, if you have some sort of a word lipid in there, that's a good thing, because most of us, again, have some form of evaporative dry eye. But in terms of what is best, again, usually the patient drives that, because I have patients telling me as soon as they put the one that says lipid on it, it's too thick, right? Others that will love it. So some need the very watery drop. If they don't mind the slightly more oily drop, then yes, for the most part, lipid-based drops. And I don't want to list any brand names on here, but we have lots of reputable brands, and that market is really thriving right now. We have more and more options every day. So what I do in my Smart Face is I list a couple brands. And then when they ask me, well, which one? I say, well, there's no perfect one. It's like shampoos. You go to the shampoo section and which shampoos are better quality shampoos. But one that works for me, you may have a different preference, right?
I like that analogy actually a lot.
Yeah. And then besides the drops, the lids, right? Which many people fail on as patients because it takes time. But those darn warm compresses and some sort of an eyelid cleanser is a good thing. So whether it's just a simple washcloth, and most patients will say it feels good. The only patients maybe that don't do well with warm compresses would be like ocular rosacea patients, especially if they're in a flare. So I always like to say, listen to your body. If it doesn't feel good, don't do it. So have your drop smart phrase along with your lid hygiene smart phrase. And then honestly, the first thing I would reach for if that fails is punctal plugs. Because clinically, I just see and hear patients come back and it makes a real big difference, because then they're relying less on drops, and usually they're not that good about those drops anyways. So anything we can do to take the work off of them makes them more successful. Same with, for example, lid. We talked about meibomian gland dysfunction and blepharitis and doing the lid therapy. That's why IPL, besides the fact that it's helpful, is so nice, because it takes a little bit of work off of the patient. So if I have a somewhat mild to moderate case and I put in, and I'm a fan of collagen plugs, and I do IPL, then that patient, for the most part, may not have to do much at home. And if they're busy, they're happy. Yeah. They don't want to spend. Now, I always say, for this to work as long as possible, as much as you can, try to keep up with the home therapy. And again, what I will do is I will compare our in-office procedures to like the dentist. I'm giving you your deep cleaning. You go home and you floss and brush as much as you can.
That's a great analogy.
Yeah.
So
I like that.
I love the teeth, because the dental world has done such a good job, right? Educating our patients about the importance of dental cleanings. And then when I talk about the lids, because again, sometimes it doesn't make sense for patients. Well, why is she making me do so much work on my eyelids? I say, it's like your gums. If you've got bad gums, you're going to have issues with your teeth. So you got to help the gums, help the eyelids.
Yeah.
So as things progress, talk about eyelid hygiene. Is there a role for baby shampoo with a little Q-tips? Warm compresses are one thing. Yeah. When do you switch, or when would you encourage that? And then also, is there still a role for omega-3 fatty acid type supplements or not?
Yes. So, I am not opposed to baby shampoo, but it's almost like, again, going to preserve drops. I feel like you can do better. So if that's all you have, and you have maybe a 70, 80-year-old that just has 3+ blepharitis, baby shampoo is going to be better than nothing, right? But I would recommend use the products made for the eyelids. The eyelids are very delicate, right? And if we still flip those, I have 2 little ones at home. If you flip those baby shampoo packages around and you look at the ingredient list is still quite hefty. It may not make your eyes water, right? Because that's what the baby shampoos are supposed to do, not have your eyes water and burn, but it's still a pretty long list. So whenever possible, if you want to go the cleanest way possible, almost like with food, right? Hypochlorous acid eyelid spray is super easy. Prepackaged eyelid wipes, different brands make those. You can do foam. So I think baby shampoo is okay, but if you can step up your game a little bit, then do that.
So when I was thinking about, all of these things and talking to my patients, I was like, I should get this. I should try it. So I did get one of those foam products, and it's in my shower. It's just a pump.
Sure.
And I use it every day, and I'm so proud of myself. But it does make a difference.
Well, I've always wondered if I should get rid of my Demodex, so I may do it too.
Yes, I'll give you a link. It's in my Amazon, but yeah, it's great. And I feel like, and I'm speaking to the people who are listening to us, I feel like we should practice what we preach.
Yeah.
Right?
Yeah.
And so you should use these products. I like the foam because I try to think about the environment.
That's right. Yeah.
And opening, individual towelettes is maybe not something we should do.
Yeah.
But there are lots of products out there. That's my...
And your Demodex blepharitis, Eric, right? So this is how you feel, right? But sometimes we don't know what we could feel like, right? Yeah. So I absolutely go after the symptomatic patients, but as a provider, it may be fun for you to see, what is this about? How can I feel better? Because you never know.
Sometimes, just going back to the orals, the omega-3s, but also antibiotics. And then we want to get to lid treatments because there's a number of things to touch on. But roles for clarithromycin or some sort of oral component, and when?
Yeah. So I am a fan of omega-3 fish oil. And usually I start the conversation. Some of my patients are pro supplements, others are not. And I always like to say you can get your omega-3s from your food, but most of us, because of being busy and we don't have sometimes access to the best food, supplementing is fine. And there's enough studies now that support omega-3 fish oil. But I always like to say dose and form matter. So we want around 2 to 3 grams I would prefer the triglyceride form of fish oil for better absorption. And to touch on that, we did have a study a couple years ago that kind of sort of showed that omega-3 and olive oil were the same, and maybe there is no role for omega-3s. But we also know that olive oil can be helpful. So there have been other studies since then that, we're not going to harm these patients with omega-3s. And holistically speaking, omega-3 can be good for other things. So unless I have patients that maybe are on, blood thinners, or maybe they bruise easily already, for the most part, it's a pretty safe supplement. But again, dose and form matters, and I also like to say get it from a reputable source. Not all supplements are made the same, right? So you want if you go order the supplement, make sure you go right to the source. Make sure you're not getting a product that's not real.
Yeah. For patients who are vegetarians, would you say that the algae-based ones are comparable? Like they should at least try that?
Yeah, I don't think there's perfect data on that, but that's what I have my patients do.
Okay.
And again, that's not going to hurt them. Do I have perfect data on that? No.
Yeah.
My guess is maybe with future, as the supplement world also, I think, is growing, maybe we'll have more data on that. But yeah.
Mm-hmm. So as things progress, would you ever add in an oral antibiotic, or would you transition to a lid treatment? You touched on that before. But
yeah. So I am also a big fan of the gut, of the microbiome, right? So whenever possible, I try not to put my patients on oral, especially chronic oral antibiotics. Having said that, usually when it comes to dry eye, you're not using high doses of the medication. So for example, here we're thinking about doxycycline and azithromycin. What I will do for doxycycline is I will do like 50 milligrams twice a day for 30 days, then 50 milligrams once a day for 60 more days. Then if a patient really has to stay on it, 20 milligrams twice a day. But my goal is always not to have my patients on oral doxycycline. Sometimes I get patients come to me that they're on 100 milligrams twice a day, and I think that's quite a bit much. Mm-hmm. I don't know what the gut is doing at that point if they've been on that for 10 years, and is it even working, right? Azithromycin, there's a pulse dosing for that. So we usually will do 1 gram once a week for 3 weeks. So depending on their allergies, those are, it sounds, again, it's slightly frustrating, but sometimes that's all the patients can do or afford, right? So I like to go after root cause, and I would, for the most part, all of my patients to some extent maybe would benefit from light therapy, but not everyone is able to do that. So So when I have patients that have, ocular rosacea, along with the eyelid being a mess, blepharitis, meibomian gland dysfunction, then I am not opposed to doxycycline, but I never reach for that first.
Yeah. So when you do your testing in clinic and you're looking at the meibomian gland, you can actually see the length and how many they have and whether or not they've had complete dropout.
Yeah.
So how do you determine candidacy and eligibility for all of these different tests? And who is the right candidate for, say, IPL versus something else?
Yeah. So, at this point, we really think of meibomian glands as once they've atrophied, they're gone. So the goal is not to lose them. We also know that sometimes, because there are some studies saying, okay, can, let's say, for example, IPL bring meibomian glands back? And the answer is no, it can't. But sometimes if a gland is dormant, you're not seeing it image on the infrared, and then you do some IPLs and there it is. It didn't grow back. It just is filled up with oil again, right? So, in the perfect world, you would start doing IPL on your mild, dropout patients, right? Because you don't want them to get to the moderate or the severe category. But again, there's no perfect algorithm for this. Most of it is patient driven. Most of my IPLs end up being done on female patients that are in the working world. They're very busy. They don't usually want to deal with the home therapies. So that's what they want to do. And again, IPL is helpful. That doesn't mean that I don't have older patients doing IPL, but for them it's tougher because maybe financially it's not possible, etc. So even if you are moderate and severe, you technically still can do IPL. But once they get into the severe category and they don't have many glands left,
it might not be helpful.
We have a conversation. We say, if you really wanted, we can try, but I don't know how much I can promise you. Now, there is some data that says you need like 6 glands left to make a difference. But again, once they're in the severe category, I have a discussion and say, we can do 4 treatments, but after those 4, if you're not noticing a difference, then we're going to be done. Now, I know some providers may keep doing them until they feel relief, but I will cap it. I won't do initially more than 4 to 5 sessions.
Okay, so the patient with mild dry eye who just wants to do it so they can move on with their life, not do so many drops, that's 4 to 5 sessions on average? When you
the first time you do it, and then you maintain with 1 session every 6 to 12 months after that.
I see.
So, IPL and other thermal expressions, we don't have anything that cures our dry eye, right? We don't have anything that cures meibomian gland dysfunction. It's a treatment, and it's a really good treatment. And, the way it works is that it has anti-inflammatory properties, right? So the IPL, light is absorbed by hemoglobin and by pigment, and it goes after the leaky vessels like the telangiectasia along your face and your eyelid margin, but it also warms up the meibomian glands. So then after each session of IPL, we do an expression, a manual expression. So you get this anti-inflammatory and clean out with the IPL versus, for example, the thermal expressions. And there's a few companies out there now that do those. You are simply heating and expressing. And I find those to be helpful for maybe sometimes my patients out of state or out of country. They want to have a clean out, but they can't be back every 2 to 4 weeks initially for their IPLs.
Yeah, the biggest effect in that moment.
Yes.
Yeah. Interesting.
It's striking how you're comparing this to dental.
I love it. I come from a long line of dentist. I can definitely get on
it fits.
This analogy.
So if practices, optometric and ophthalmology practices out there considering, adding in these in-office procedures, what advice do you have? What should they think through first? Any suggestions for them on how, what they should have in place and what they should look for and gain or challenges along the way?
The one thing I would say, and we touched on this already, is if a patient's coming in for a comprehensive exam, and you are doing a comprehensive eye exam, usually you're not going to be probably successful in encouraging some of these in-office procedures just at that one visit because there's too much to cover. The patient has to be on board. They have to understand. They have to see. The biggest thing about my dry eye consults is that I will show the patients the images that we took across the way. So I will show them the meibomian glands. I will show them the Placido's disc of the non-invasive tear break-up time. Because seeing is believing. So I would suggest that yes, everyone should do dry eye because, again, the prevalence is so high. But you should separate that from a comprehensive or a retina exam and say, come on back in, let's do some imaging, let's show you where you are, and then together we decide how we want to proceed. Because then probably if you're investing in technology that's costing a lot of money, I mean, obviously you're doing it for the right reasons, but it has to be used.
Yep.
And if it's not being used, then you'll feel like you failed. So give it a chance.
Sure.
Yeah.
Can I ask 2 short questions? I know we're getting to time. The first one is just very short. For punctal plugs, let's go back there for a second.
Sure.
I'm assuming there are patients that aren't good candidates for punctal plugs, maybe really inflammatory, or are there patients maybe you think, oh, their rosacea is not controlled and we shouldn't do punctal plugs because then there'll be more inflammatory growth factors. Who should you not put punctal plugs in is the question.
And exactly, it's what you said, Brittany. Those patients are never seeing me once and then we're done. So it's not like I'm trying to do everything all at once. Clean up the eyelids, control the inflammation before you plug them, because that's how you're going to have successful punctal occlusion. If the eyeball is inflamed, angry red, and on top of that you plug them, I compare that to a dirty sink. You put a plug in and you got a dirty sink that just sits there. Let's clean up the water and then fill the sink with clean water and then plug it.
Yeah.
That's when the patients are going to be successful. And even the punctal plug world is growing. We have silicone plugs, we have collagen plugs. Now we even have a hyaluronic acid gel that we can inject in the puncta. And over the years, I've really become a fan of collagen, because now we have 6-month ones. You always have to keep the eyelid anatomy in mind as well. You can't just plug everyone. If someone's puncta is kind of turned inward a little bit and you maybe put a silicone plug in that has a phalange, a tip, you're going to cause irritation. You're scraping the eye. And also you're asking, and this may not be very scientific, but the eyeball is going to get angry and maybe push that plug out, right? So the eye has to be happy, and then you plug good tears, which again, I use all 3 forms of punctal plugs, but I end up doing lots of collagen.
Yeah. So it sounds like there's been a lot of change recently in the field. How do you think this, final question.
Yeah.
How do you feel like 5 years from now, this conversation is going to be different? Thinking about what's going on scientifically, technology-wise, this recent, updating guidelines and definition. How will this conversation be different?
Yeah, so I think we are probably going to move more towards even more in-office procedures, because unfortunately our lives are only getting busier. So we are going to try to find therapies that are like extended release type therapies, right? Not that you have to constantly be putting drops in your eyes. Maybe we put a punctal plug in that has cyclosporin in it, whatever it may be, right? But so that the patient comes in, you do it for them, and then maybe they do a little bit of work at home. Because actually one of our own doctor now did a study with a group not too long ago where they showed us that some of these patients are spending 1 to 2 hours a day on their dry eye regimens, right? I mean, that is not a way to live. So I think biologics are going to be a way of the future, regenerative medicine. I think we're going to look at the gut even more. And again, I think the in-office procedures and treatments that give our patients freedom and not take so much of their time.
I just thank you for being here with us, but in particular, this is a topic that frustrates providers
and patients
chronically. And I just to be able to have this moment in time where you can share your expertise to help everybody out there listening have some degree of optimism, hope, and a better toolkit for caring for these patients. We just thank you for sharing that with everyone.
Absolutely. Thank you so much for having me. And if anyone ever has any questions, feel free to reach out.
Thank you.
Yeah, thank you.
You can find all episodes of the Mayo Clinic Ophthalmology Podcast on our website, YouTube, or on most podcast platforms.
Thank you for listening, and we definitely look forward to sharing more on our next podcast.